So based on the information we've just discussed, we need to figure out what movement disorder James is experiencing. With his symptoms, we did not see the sustained muscle contraction that we would expect to see in dystonia, nor did we see the intense inner restlessness feeling that patients with akathisia have, nor the inability to sit still. Now, he did have a history of drug-induced Parkinsonism, so we need to consider a reemergence of those symptoms. However, this time around, he did not have any change in his antipsychotic or change in the dosage of his current one, and that makes it less likely. And furthermore, when he had drug-induced Parkinsonism in the past, benztropine did have a beneficial effect for him, but it did not this time around. So all of that would be speaking against the possibility of drug-induced Parkinsonism. One of the keys that I found to differential diagnosis of drug-induced movement disorders is matching up the characteristics of the symptoms with the timeframes of their onset. For instance, with dystonia, which is a sustained muscle contraction, almost always that's going to occur within the first 5 days of starting the treatment. Still early on, within the first week or so, would be akathisia. Akathisia is an intense internal sense of restlessness that's accompanied by the patient being physically unable to stay still. Within the first weeks to months after starting a new treatment or increasing the dose, we may see drug-induced Parkinsonism, and that it consists of a generalized bradykinesia, which is a slowness of movement and stiffness, but it may be accompanied by several focal areas of hyperkinetic movements, which are tremor in this case. And finally, we need to consider tardive dyskinesia, or TD. TD starts months to even years after the antipsychotic is begun and consists of chorioathetoid types of movements. Dyskinesia can also occur after a dose reduction or stoppage of an antipsychotic, but if the symptoms resolved within 1 to 2 months after that, we consider that a withdrawal dyskinesia instead of tardive dyskinesia. However, because James's movement started with a stable dose of an antipsychotic, that was not a factor in his case. Other things we need to consider are that James has a mood disorder diagnosis, in this case bipolar disorder. He's also received a first-generation antipsychotic in his past, haloperidol, and that gives us another potential clue to the type of movement disorder that he has. Another consideration is that he was on benztropine for a prolonged period of time in the past, and long-term usage of anticholinergics can increase the risk of certain types of movement disorders. So based on what James has experienced, his risk factors, concomitant medications, the timing of symptoms, we can conclude that his symptoms are most suggestive of tardive dyskinesia. Tardive dyskinesia, or TD, is an involuntary movement disorder that occurs in association with any medication that blocks dopamine receptors. Most commonly, we're going to refer to those as antipsychotics, but other medications, such as certain gastrointestinal medications, can also block dopamine receptors. As I mentioned, we typically see TD occurring very late, which is actually where the name comes from. The tardive is the French word for late, like when my kids go to elementary school and they're tardy for their classes. The earliest we tend to see TD is after a few months of treatment, and oftentimes it's even years after starting the medication in some cases. The symptoms can even start after the patient has stopped the antipsychotic, as long as they persist past 1 to 2 months. There's just a lot of variability in tardive dyskinesia. The characteristics of TD are also distinct. They're non-rhythmic movements, unlike tremor, and they can range from writhing serpentine motions that we would call choreiform to faster tic-like athetoid movements. It's best practice to use standardized rating scales such as the AIMS, or the DISCUS if you prefer, every 6 months in patients who are high risk for tardive dyskinesia. For people who are not high risk, it should be at least 1 year per current guidelines, and that's for any patient taking any dopamine receptor blocker, such as any antipsychotic. In both the AIMS and the DISCUS, individual body regions are rated from a scale of 0 to 4, where 0 means there is no movement that's involuntary, 1 is potential involuntary movements, but they could be on the extreme range of normal, and then 2, 3, and 4 going from mild, moderate to severe confirmed dyskinetic movements. As you can see from this diagram, really any part of the body can be affected by tardive dyskinesia. Importantly, it's not just the muscles that we can see, such as the arms, the lower extremities, the trunk, the muscles of facial expression, but also muscles we can't see. The esophagus, the diaphragm, and other muscles internally can also be affected by TD as well, and these can result in potential real-world consequences for these patients. It's important to screen every patient who's on an antipsychotic medication for TD. And when we talk about screening, we should be consistent with the American Psychiatric Association guidelines. And what they recommend is the usage of those standardized rating scales. However, we need to go beyond that. And also in 2020, an expert consensus group used a Delphi method to achieve some other recommendations for TD, which state that we should be doing brief semi-structured exams on patients with antipsychotic treatment, even between those structured examinations. That means at least thinking about TD in every visit with every patient on any antipsychotic. These would be used to supplement those rigid formalized screening tools. And as you can see, some of the elements we capture in the Ames exam would rate involuntary movements in the muscles of facial expression, movements of the lips, tongue, the upper limbs, the lower extremities, and then the neck and trunk. However, we have to move our thought process from thinking about the severity of TD as being the sum of those 7 first items in the Ames to a more modern approach where we look at items 9 and 10, the patient's awareness of the movements and their incapacitation due to those movements. Ames is nothing but a number, I like to say, and it's more important to think about how TD is impacting the patient's function and their quality of life. But in order to be able to find out if a patient is aware of their movements and how they're affecting the patient's functionality, we have to learn how to ask them the right questions. This is not something that we've typically been taught how to do in mental health, so there's a lot to consider here that we have to think about.